अच्छा एक मिनट रुक जाइए, 2 मिनट और रुक जाइए।
ऑफ कौन सा करना है? ये देखिए इसको यहाँ Good morning, everyone. Today is my seminar on fungal infection, CNS fungal infection, and I will discuss the topic under these headings. First of all, I will discuss some clinical cases, then introduction, epidemiology, pathogenesis of CNS fungal infection, then etiological agents associated with the fungal infection of CNS. Then I will move to diagnosis of fungal infection, and finally treatment of fungal infection of CNS. Case 1. A 50-year-old female from Lalit district, Nepal, and presented to Patna Hospital Emergency Department in December 2018. And her complaint was abdominal pain since 2 days and multiple episodes of vomiting. And after history taking, she give history of amlodipine and atenolol for hypertension treatment, and hysterectomy done 5 years back due to fibroid. And on examination, her blood pressure was 170 by 100 mmHg, and the pulse rate was 88 beats per minute, and temperature is 98.98 degree Fahrenheit. And after abdominal examination, there was tenderness in right upper quadrant, and all and and laboratory parameter like hematological and biochemical laboratory parameter was normal, and ultrasound is the abdomen. There was calculi in the gallbladder, and gallbladder wall was thick. According to doctor, the provisional diagnosis of this lady was biliary colic. So she was admitted to surgical ward for cholecystectomy, and initially she was on conservative management with intravenous fluid, antiemetic drugs, and analgesic. And their pain subsides, and blood pressure was also normal. But after second day, she developed headache and fever around 101 degree Fahrenheit on fever, and fever on fourth day. Then empirical treatment started. 1 gram twice injection ceftriaxone, and next day she developed altered sensorium, and she was disoriented, and neck stiffness. Then plain CT of head was planned, and CT head was normal, and her CSF analysis was also normal. On on India Inc. Preparation of CSF, and it was negative, and bacterial culture, so after 48 hours also negative. Then CSF cryptococcal antigen was latex agglutination of CSF for cryptococcal antigen, it was positive, and she was HIV negative, and then on the basis of cryptococcal antigen latex agglutination, diagnosed as cryptococcal meningitis. Then patient shift to the ICU, and she was on liposomal amphotericin B. Dose was 4 milligram per kg per day, and along with fluconazole 800 milligram daily, and ceftriaxone continue. Her family member could not afford due to the poor economic condition. So liposomal amphotericin B is a expensive drug, so it was stopped initially, and patient was only on the fluconazole tablet. Then patient status was deteriorated, and she developed right side weakness. Then MRI of brain was planned, and so acute infarct involving the left parietal lobe and basal ganglia with multiple acute lacunar infarct in bilateral, frontal, and parietal lobe, and between the cerebellum. For the infarct, she was taking aspirin 75 mg, that is anti-platelet drug, and the atorvastatin 40 mg daily to reduce the bad cholesterol, and increase good cholesterol and reduce triglyceride also. Then her family member arranged liposomal amphotericin B, B. And for 2 weeks course of liposomal amphotericin B along with fluconazole, and there was patient improved gradually, and improvement in the higher mental status seen since after 4-5 days of taking the amphotericin B along with fluconazole. After completion of 2 weeks of amphotericin B, her mental status was normal, and she could walk on her own on leg with some residual weakness in upper limb. Then patient discharged, and daily fluconazole 800 milligram for 8 weeks is advised. Actually, the case 1, it indicates that in cryptococcal meningitis, liposomal amphotericin B is the drug of choice. Without liposomal and amphotericin B, patient was not improving. And second point, only on the basis of India interpretation, we cannot exclude the cryptococcal meningitis. Now I move to the case 2. That is case 2. 11-year-old boy admitted to the Department of Neurosurgery in Imam Hussain Hospital in 13, and his complaint was weakness of left limb after generalized seizure, and no any past history like a previous illness, drug reaction, trauma, or any chronic illness. And his Glasgow Coma score was normal. Out of 15, there 15. And on examination, their systolic was 110, blood pressure systolic was 110, and lower limit was 80, and pulse rate was 90, and their respiratory normal, and temperature also 37.2 degrees centigrade. And left limb weakness is 3/5. 3/5 indicates that actually 1/5 indicates that muscles is thick but no movement. If 2/5, it indicates able to move but not against gravity, and 3/5 indicates move and against gravity also, but no against resistance. It indicates 3/5. And his brain MRI so in frontal lobe there is extensive surrounding lesion and ring enhancement around the lesions in the frontal lobe. Now, the doctor actually according to doctor, initially they planned for CT, abdominal and pelvic CT. They think maybe there is a chance of metastatic cancer from this part, abdominal pelvic part, move to the brain. So they plan abdominal pelvic and CT initially, and was normal. Then they CT of lungs, and the finding of CT lungs, there was multiple nodule with irregular and spiculated margin with the parenchyma, and it suggests metastatic lesion, spiculated like lesions having a spike, irregular margin, and it is a sign of cancerous tumor. But then patient decide to remove the brain mass, and for pathological assessment showed after removing the mass there was a granulation lesion, giant cell, and area of necrosis, fragmentation of hyphae within the lesion, and cytoplasm of macrophages. They performed the galactomannan assay and was negative. Then culture of the brain lesion and pulmonary lesion confirmed the presence of aspergillus flavus. Despite of galactomannan assay was negative. Patient was no immunocompromised. Either their viral marker was negative. Their patient was started on fluconazole, and dose was 6 milligram per kg, and twice at day 1. Usually dose was 6 milligram per kg, that is bolus. Then 4 mg per kg twice daily for 3 along with prednisolone for 3 months. The was resolved with continued treatment, and there was no sign of recurrence in follow-up study 1 year later. Uh, Actually, cerebral aspergillosis it was a case of cerebral aspergillosis and is rare in immunocompetent, but mortality is high. Actually, this line indicates that if immunocompetent patient infected with cerebral aspergillosis, in that person mortality will high in comparison to immunocompromised patients, because in immunocompromised patient and the most common site of aspergilloma is the frontal area, because in the MRI lesion was present in the frontal area, and aspergilloma is the lung. In the lung is the source of CNS infection, and if actually this indicates that if a patient having frontal lobe lesions and on brain tissue, hyphae seen, despite of galactomannan antigen negative, uh, this is cerebral aspergilloma, which consider that means the galactomannan antigen is negative, it will not exclude aspergillus infections. And in case of cerebral aspergillosis treatment, voriconazole is the drug of choice, and initially it was 4 mg per kg, and then it was reduced to half for 3 months. Actually, there is pre-operative diagnosis of cerebral fungal lesions is difficult and frequently missed, and voriconazole has better CNS penetration than amphotericin B. For the treatment, both medical and surgical intervention are required, because without surgical intervention, we cannot assess the hyphae in the tissue. So, surgical along with the medical treatment, surgical intervention is also useful. Then we move to the topic proper, and first of all, I will discuss the introduction part. Fungal infection of CNS is increasing since 2 decades, because nowadays there are increasing use of steroid therapy, and patients become immunocompromised due to higher prevalence of diabetes, and there are so many conditions which improve the immunosuppressive condition of patients. So infection of fungal CNS now increases nowadays. And invasion of CNS depends on the immune status. I already told the patient is immunocompromised, more chance to invasion penetration of fungal to CNS, and the virulence of fungal strain also. And the fungi involved in CNS infection are yeast, filamentous, and dimorphic fungi. Then I will just count some example of yeast associated with fungal infection: CNS, Candida, Cryptococcus, Trichosporium, filamentous fungi, Aspergillus, Rhizopus, and Mucor, and dimorphic fungi, that is Blastomyces, Histoplasma, Oxalides, and Paraoxalides are associated with the fungal infection CNS. And these are the list of several risk factors in people who are having fungal CNS infection, like HIV/AIDS patient, transplant recipient, patient on chemotherapy, drug and steroid, also hematological disorder, and chronic kidney patient, and CGD, that is chronic granulomatous disorder. It is also a risk factor of fungal CNS infection, because in this condition, this is a chronic granulomatous disorder in which the NADPH oxidase is deficient, because NADPH oxidase is present on the membrane and fibrosome membrane also, and fibrosome kill the microorganism, and this microorganism is engulfed by the neutrophils. So neutrophil finally function of neutrophil is deteriorated or disturbed. So in chronic granulomatous disease, the immunity will decrease and patient will immunosuppressed. So in CGD, chronic granulomatous disorder, it is also a risk factor for fungal CNS. Then CARD9 deficiency. CARD9 deficiency actually it is associated with the Candida infections. In a patient having CARD9 deficiency, so Candida infection is actually card9, it activates pro-inflammatory and anti-inflammatory cytokine, which uh, which is necessary for which is necessary for inflammation and apoptosis. In the card9 deficiency occur, there is no apoptosis and inflammation, so it is also immunosuppressive condition in candida. And if a person underwent neurosurgery, it is also a risk factor for HIV CNS infection. And prolonged and premature infant is also. Then diabetic ketoacidosis. Actually, this slide indicates a specific risk factor associated with mucormycosis, cryptococcus, histoplasma, candida. Actually, there are some common risk factor, but if a patient having the chronic gallbladder disorder, card9 deficiency, and underwent neurosurgery and premature infant, mostly diagnosis made candida. The candida will be the culprit for their CNS infection. If a patient gives a history of contact with bugs, also in this case, cryptococcus and histoplasma will consider. They may be considered most probable cryptococcus and histoplasma will be the cause for their injury. In patient having diabetes and they got burns and renal failure and intravenous drug usage, the mucormycosis infection possibility. Now these are syndrome, clinical syndrome of neuroinvasion caused by fungi. That is the actually classification on the anatomical classification of CNS fungal infections. So which part is affected of CNS, central nervous system, by fungi. If you talk about critical syndrome, the first is meningitis, just inflammation of meninges. If meningitis, the probable fungi should be cryptococcus, coccidioides, and candida. While if along with the meningeal inflammation, some part of brain is also involved, that is meningoencephalitis. In these cases, cryptococcus causes candida, and if brain abscess, then aspergillus. Already I told the case number 2. The case was the brain abscess and aspergillus was in this case was the etiology. So brain abscess, aspergillus, candida, these are the rhinocerebral, mucorrhizopus abscedia, and skull-base syndrome, aspergillus, mucorrhizopus, and disseminated cases. Actually, there are more than one fungi associated with meningitis, like candida is also risk factor for meningitis, meningitis. But these are all rhinocerebral. And these are the mode of CNS infection, that is the CNS infection, that is the if intracranial devices use, the possibility of candida species infection candida species, you can use molds, and direct extension from sinuses or mastoiditis. That is the aspergillus species or mucormycosis. If infection transforms from sinuses or mastoiditis parts, so there may be direct extension of fungi goes to the brain and disseminated from pulmonary infection, molds, cryptococcus, epidemiology fungi, and hemogenous spread like intravascular catheter, abdominal surgical site, internal candida species, and non-candida ist also, and aspergillus and mucus. And direct manipulation, spinal tap and direct trauma would also mode of CNS infections. Like talk about epidemiology. If about the cryptococcus is the most common opportunistic CNS fungal infection in the HIV positive patient. Actually, these figures are 82.2%, 48.1%, and 27.6%. Actually, it indicates the patients out of 100. If present in HIV AIDS patient, Epidemiology. Cryptococcal neoformance, the most common approach is CNS infection in HIV positive patient. If we talk about the figure, 82.2% of HIV patient showing the cryptococcal neoformance. In transplant recipient, the percentage of infection of cryptococcal neoformance was 48.1%, and immunocompetent immunocompetent 27.6 people out of 100 are infected with the cryptococcal neoformance. And if cryptococcal meningitis is prevalent. Kumar is around. Network issue, I think. And cryptococcal meningitis is prevalent in sub-Saharan Africa, Asia Pacific region, Latin America, Europe, and North Africa. And about Candida albicans, it is isolated and immunosuppressed and immunocompetent both. But nowadays infection by non-Candida albicans increases. And CNS In hematopoietic stem cell transplant patient, the incidence of neuroinfection by Candida albicans is 33% and 77% of non-Candida albicans species. It indicates that the infection by non-Candida albicans is increasing nowadays. And in case of infant having birth weight less than 1500 gram, so CNS involvement by Candida. In newborn, the CNS involvement are 66% with disseminated candidiasis and 80% with candidial endocarditis. And now I move to the pathogenesis of fungal infection of central nervous system. Actually it is not fully cleared, and the first step of pathogenesis of fungi is the filtration of fungal pathogen across the blood-brain barrier, and it is the initial and essential step towards the CNS involvement. And there are three mechanisms associated with the fungal infection of CNS. One is transcellular, another paracellular, and the last one is Trojan horse mechanism. The first two, 1 and 2, are the direct mechanism to move the pathogen inside the CNS to the blood across the blood-brain barrier, and third one is Trojan horse mechanism. It is basically indirect way of mechanism. Now transcellular migration. The pathogen that cross the blood-brain barrier through endothelial cells, and after crossing the blood-brain barrier, the pathogen is in direct contact with the astrocytes, microglia, and neuron. And there are two mechanisms of transcellular. Transcellular is the one out of three mechanism, and the transcellular mechanism is direct mechanism of CNS filtration of pathogen towards the brain, and one is absorptive and another one is ligand receptor. In absorptive mediated depends upon the charge interaction among endothelial cells, endothelial membrane, and then it is transported across the cell and released into the CNS. The receptor ligand mediated transcytosis, it requires the receptors to transport pathogen through the blood-brain barrier, and receptors are transfusion receptors, insulin receptor, and LRP1 and 2, that is lipoprotein receptor, including protein 1 and 2. And another one is paracellular CNS penetration. In paracellular CNS penetration, there is a disruption of the tight junction. Actually, in this, the fungal pathogen attaches to BMEC, a blood membrane endothelial cell, and enter the CNS between two endothelial cells. And I will show the figure in the next slide. The tight junction, the anchor that hold adjacent endothelial cells close together are disrupted during the mechanism of microbial transfer. I mean, in paracellular CNS penetration, it occurs through the due to the disruption of the tight junction of endothelial cells. Now, last one, the Trojan horse method. It is an indirect method, and in which the infected phagocytes used to carry the pathogen from outside to the CNS, inside the CNS, and already told indirect method, and in which actually blood-brain barrier is permeable to phagocytic white blood cells, and the phagocytic white blood cells regularly circulate in blood and provide immunological surveillance. And in some pathogen, actually pathogen copy this natural process and use it to their advantage. And microbial transfer occurs with the transmigration of an infected phagocytes. And these are the figure indicates the A indicates the transcellular, B paracellular, and C is the last one, Trojan horse mechanism. In Trojan horse mechanism, actually purple color is a pathogen, and it inside the CSF along with the phagocytes, and B is the paracellular between two endothelial cells, in which it disrupts the tight junction and it enters from blood to CSF, and finally the one is and already paracellular and the transcellular. In transcellular mechanism, the charge mechanism involved to carry pathogen from blood to CSF. Now, Cryptococcus neoformans can cross the blood-brain barrier by both direct and indirect mechanism. To trigger the translocation process, there is interactions between protein molecule and blood-brain barrier necessary. The CPS1 gene is required for Cryptococcus neoformans. Cryptococcus neoformans utilize paracellular and transcellular, and their CPS1 gene is necessary, which adhere to the surface protein CD44 of human brain microvascular endothelial cells. In a state of reduced immunity, actually immunosuppressive condition is also a risk factor for fungal infection in CNS, and in the reduced immunity, that is immunosuppressive condition, in which the blood-brain barrier permeability already increases, and which promotes the penetration of fungi into the brain. So usually in the condition of reduced immunity, the pathogen easily cross the blood-brain barrier and reach to CNS. And the fungal pathogens get to the brain parenchyma and proliferate, causing the brain inflammation. That is the encephalitis or meningitis. And activation of nerve cells by fungal cells and their release of cytokine and chemokines play a role in the pathogenesis of fungal infection. Actually, pathogenesis, the cytokine and chemokines involved in the pathogenesis of fungal infections. These are list of ecological agents. I already discussed that Cryptococcus, Candida, Aspergillus, Mucormycete, Demataceous, Dimorphic fungi, and some unusual fungi like yeast and mold. It is also involved in the fungal CNS infections. Now I will discuss shortly about the Cryptococcus species. In the Cryptococcus, two species, neoformans and Getae, are responsible mainly. The two species like Cryptococcus neoformans and Getae are responsible for. And if patient give history of pigment dropping, so we move toward the neoformans. We think about the neoformans. And if we talk about the Cryptococcus Getae, it is seen on eucalyptus and other tropical and subtropical trees. And this primarily involve the affect the lungs. Then from lungs it spreads through either continuity or through the hematogen or through the lymphoid pathway, resulting in involvement of CNS. And infection is also possible through the skin if fungal cells enter the wound. Actually, there are two routes of entry of Cryptococcus in our body. One is through the lungs, and another is direct invasion of Cryptococcal fungal through the wound. Now, and penetration into CNS. Already I told there is a Trojan horse mechanism involved in the transporter, and in immunocompetent CNS invasion is associated with poorer prognosis. Because there is involvement of brain in immunocompetent more than immunosuppressive and HIV patient. That means this line indicates that if a patient is immunocompetent, and in this patient there is a more chance of infection spread from lungs to brain in comparison to HIV infected patients or other immunosuppressive conditions. So CNS invasion is poor prognosis in the brain, immunocompetent patients. And Candida species, and it is the most common opportunistic fungi in human. And CNS involvement by disseminated candidiasis or neurological surgery. Involvement are two either disseminated or through the neurological surgery, and it forms biofilm. It's aquatic, it forms biofilm, and mortality increasing to 90% in CNS involvement. And Candida albicans is commonly associated from both immunocompromised and immunocompetent patients. And now Aspergillus species. The mainly two species, one is fumigatus and flavus. In immunosuppressive condition, fumigatus is mainly seen, while in immunocompetent, flavus involved. And aspergillosis is mainly associated with lungs, while 40% associated with extrapulmonary infection. Among extrapulmonary, 10 to 20% involve lungs. involves CNS involvement. CNS involvement. And the most important risk factor for brain infection are neutropenia and corticosteroid. In patient having neutrophils count less than 1500 count per microliter and giving history of taking corticosteroid, the possibility of aspergillus infection enhance. Now, the risk of aspergillosis are ear infection, sinusitis, mastoiditis, and the dissemination of fungal agent of the brain. There is a direct dissemination of uh, aspergillus fungi to the brain. If a patient is infected with patient having ear infection or inflammation of sinuses like paranasal sinuses or infection of mastoid region, there is a possibility of dissemination of ear fungi to the direct dissemination to the brain part or or CNS also. And the most common source of infection is immunocompetent. I told earlier, both immunocompetent and immunosuppressive are the uh, risk factor. Both are susceptible to aspergillus infection. And if you talk about the immunocompetent patient, so more than immunocompetent patient having aspergillus brain infection by the sinusitis. Well, approx 60 to 70% of aspergillus infection in immunocompetent through the sinus inflammation. And the most important virulence factor of aspergillus species is mycotoxin. Mycotoxin is and which kill the microglia, astrocytes, and neuron. And CNS involvement with high mortality rate of 90 to 100% in immunosuppressed individual and 40 to 80% in immunocompetent. Mucormycetes. Mucormycetes includes mucor, rhizopus, rhizomycin, and DCFM. And it infection of inhalation of spores or by damage to the skin or mucous membrane. The most common form of invasion is rhino-orbital cerebral mucormycosis. Neutropenia or glucocorticoid therapy is considered risk factor for rhinocerebral infection and or pulmonary infection. And actually, if patient giving history of diabetes, it is also a risk factor. Diabetes is usually associated with rhinocerebral mucormycosis. In diabetes, actually the reason behind diabetic patients, monocytes, macrophage, and neutrophil function is impaired, so immune response is delayed, and increased glucose level favor the growth of fungi. So in diabetic patient, due to level of increased glucose level, favor the growth of mucormycetes, and which leads to rhinocerebral disease. And the most common identified species associated with is Rhizopus rhizus. Now, demetaceous fungi. The demeter dark colored fiber due to melanin deposition. Melanin is considered their most important virulence factor because it interferes with the microglial cells. In human, leads to phyomycosis, along with other infection leads to disseminated cerebral infections. Demetaceous fungi exhibit neurotropism and can cause primary infection in the skin, in the CNS. If we talk about the preponderance of demetaceous infection in male and female, male are more affected by demetaceous fungi in comparison to female. In world level, male are affected 3 times more with female, but while in our country, the ratio is increased 14:1. And most characteristic symptom of CNS involvement is hydrocephalus. Hydrocephalus, that is ventricles, accumulation of CSF fluid in the ventricles, hydrocephalus, and acute and chronic meningitis. Some important dimorphic fungi associated with CNS infection are Histoplasma capsulatum, coccidioides, Blastomyces dermatitis, and Tyleromyces marfanoid. etc. These are list of some unusual fungi associated with the CNS infection. One is yeast, and another one is mold. Mold and yeast. In yeast of the genus Trichosporum causes fungal infection of the skin and subcutaneous tissue. Among yeast, that is a Trichosporum, that is an unusual fungi, leads to CNS mycosis. In Trichosporum acai is most frequent etiological factor of brain lesion, and Trichosporum cutaneum and then and also C. And patients were found to have chronic meningitis, brain abscess, and hydrocephalus. In trichosporonosis, patients have elevated levels of galactomannan antigen, which is characteristic of infections caused by Aspergillus. Actually, this is an important point, important line. If a patient of cerebral abscess, if a patient of if a patient having the CNS infection of brain by fungi, galactomannan antigen assay makes a DD of trichosporum infection and Aspergillus species. That means if galactomannan antigen positive, not only confirmatory indication of Aspergillus, it might be a infection of trichosporonosis also. And another one unusual fungi is Fusarium species. It possesses several virulence factors like mycotoxins, including trichocicin and fumonisin, which suppress humoral and cellular immunity. Fumonisin B1, the fungus most common mycotoxin with cerebral fungal invasion leading to neuron axon demyelination. And the mortality in fusariosis is around 50-80%, and multiple brain abscesses and meningitis. So this is also a fusarium which also associated with multiple brain abscess. Okay. And brain abscess is also associated with Aspergillus. But in Aspergillus, generally single brain abscess. But in case of fusarium, there is a multiple brain abscess. And also show the sign of meningitis. Now the diagnostic part. The diagnosis by either by microscopic, by histopathology, and serology. And neuroradiological characteristics of fungal infections are often non-specific because every finding having the many duty. If we only see the radiological finding, we may not assess their diagnosis. And nowadays, the use of PCR-based assay needs to undergo standardization because PCR-based test is a costly, expensive test, and it is only used in the country which are economically sound. So PCR should be standardized. And according to URTC and MSG criteria, the diagnosis of fungal infection is made on the basis of their combined interpretation of risk factors, clinical symptoms, and imaging result. By only consider risk factor or either clinical symptom or imaging result, we may not clearly diagnose any fungal infection disease or etiology. We have to correlate everything to make a final diagnosis. And the diagnosis of invasive mycosis require biopsy of the involved tissue, followed by their culture and histopathology. And specimen for biopsy is brain, meninges, CSF, or ventricular fluid. And biopsy material stained with hematoxylin eosin stain is particularly with gomorimethambine GMS or PAS. And serological tests also used to help the diagnosis, like ELISA, enzyme immunoassay, indirect hemoglobin technique also. Serum assays for galactomannan in invasive aspergillosis, and fusarium also expressed galactomannan antigen in serum or CSF, so does not constitute definitive diagnosis of CNS. I told in previous slide, if fusarium also show the galactomannan antigen test positive, and Aspergillus already show. So only show the galactomannan antigen positive,
we cannot 100% sure it may be Aspergillus. One disease also possible, that is Fusarium infection. And one is a 1,3-beta-2-glucan, it's a cell wall constituent of Candida and Aspergillus species. So it is also make a DD of between Candida infection and Aspergillus infection by glucan species constituent. So several other fungi. So it is not a specific serum marker for invasive candidiasis and aspergillosis. So it all indicates that according to the guideline, everything, risk factor, neuroimaging, and culture, serology, every on the basis of everything we will assess their diagnosis. If we talk about the cryptococcal meningitis diagnosis, actually when I study the many article, either cryptococcal meningitis, histoplasma capsulatum, aspergillus, is this article are available in net. So I will discuss diagnosis of cryptococcal meningitis. And for cryptococcal meningitis, CSF was taken as a sample, and culture is a gold standard for diagnosis of cryptococcal meningitis, but it takes time, 1 to 2 weeks. And and if in India in microscopy, and actually India is a negative strain because it negative strain, and in India we see the halo of light in light microscope because strain is not taken by the thick Cryptococcus capsule. And if you talk about the sensitivity of India, it's low, 86%. If we diagnose 7 cases, out of 7 cases, 1 is missed in the India. So improve the sensitivity of India centrifugation process, increase the sensitivity of microscopy. Now cryptococcal meningitis antigen test. The antigen test, that is a latex agglutination. The cryptococcal antigen can be identified by using latex agglutination test, having good sensitivity and specificity, about 99% in serum, and titer should be 8 to confirm the diagnosis of cryptococcal antigen latex agglutination test. If titer comes 4 up to 4, then it's a presumptive diagnosis for antigen test. And there are other diagnostic method like PCR, that is a film array meningitis encephalitis panel, and it is a multiplex PCR, and detect 14 meningitis or encephalitis pathogen. Actually PCR is not pathogen, multiplex PCR used to diagnose a patient having meningitis symptoms. And nowadays in our lab, MyDTF is available, which is also diagnosed cryptococcal antigen. And diagnosis of CNS aspergillosis. Actually in CNS aspergillosis, actually in intracranial mass, patient having the intracranial, patients show the intracranial mass. In the case of intracranial mass, the lumbar puncture is contraindicated because there is a possibility of cerebral edema. Actually in intracranial mass, lumbar puncture should be contraindicated because there is a possibility of, or as a side effect, there cerebral herniation syndrome or abscess rupture. If CSF is taken, then CSF finding will be the pleocytosis. Neutrophils and lymphocytes will rage in their CSF, and protein was moderately elevated, and glucose was normal. CSF glucose was normal, and organisms are rarely found in CSF. And if find, the branching septate hyphae and conidia of aspergillus species are seen in H and E strain and pass reagent, but most rarely in GMS strain. And KH mount, weight mount also demonstrate the aspergillus. Uh, MRI is also a diagnostic modality, ring enhancement lesion. If you culture on supratextual agar, we see the conidiophore. However, blood and CSF culture are frequently negative, and serological tests, there are double diffusion, counter-immune autopharesis, and immunofluorescence or ELISA help to diagnose the aspergillosis. Detection of histoplasma antigen or antibody in urine and serum to diagnose the CNS. If we histoplasma to diagnose the histoplasma. For histoplasma diagnosis, urine and serum sample is useful to diagnose the CNS infection. We have to see, we will see the antigen antibody histoplasma in the urine and serum. And cryptococoma is an intracranial mass lesion indicated by a ring-shaped enhancement lesion in MRI in cryptococosis with or without cystic changes. And most common location of mass lesion includes basal ganglia, cerebellum, or parietal. In case of demetaceous fungal infection, the most important symptom of CNS invasion are black necrotic brain tissue, black pus, and black CSF. In X-ray, ring and hyperdense or hypodense lesion. If a black CSF is seen in patient, then we may think about demetaceous fungal infections. CNS. More accurate confirmation of diagnosis and identification of fungi by PCR assay, while no standardized and validated detection method based on PCR. Most of PCR protocol developed for the diagnosis of invasive fungal infection, mainly for Aspergillus and Candida species. And PCR technique performed on CSF food sample may well become the new gold standard for the diagnosis of CNS infection. Now, culture is a gold standard for diagnosis of fungi. If we move to the treatment part of central nervous system, there are many antifungal drugs which penetrate the central CNS, central nervous system, easily, and which partly among antifungal drugs, voriconazole, fluconazole, and flucytosine are penetrate in the CNS, while itraconazole and posaconazole only penetrate to a minor degree. These are the guideline of treatment of cryptococcal meningoencephalitis. If a patient, that is the first line therapy, fungal CNS infection, cryptococcal meningoencephalitis. Initial therapy start with the if the patient is immunocompromised or immunocompetent, their protocol is different. For initial therapy in non-HIV infected and non-transplant patient, there is amphotericin B and starting with amphotericin B plus flucytosine greater than 4 weeks. Then amphotericin drug for greater than 6 weeks for flucytosine intolerant patient, and if the patient is not tolerated flucytosine, in cryptococcal meningoencephalitis, we will provide drug amphotericin B along with flucytosine. If flucytosine is not tolerant patient, then liposomal amphotericin B or amphotericin lipid complex combined with flucytosine plus 4 and they are the intolerant patient. And their consolidation therapy, fluconazole 400 to 800 mg per day for 8 weeks, and maintenance therapy, fluconazole 200 mg per day for 6 to 12 weeks. If in children, just drug dose is amphotericin B drug 1 mg per day IV plus flucytosine 100 mg per day orally in 4 divided dose for 2 weeks, and liposomal amphotericin B 5 mg per day amphotericin B liposomal complex in patient. Now, if patient is cerebral cryptococoma, actually cryptococcal meningoencephalitis patient with cryptococcal meningitis, the drug choice of amphotericin B and flucytosine combination will provide the cryptococcal meningitis. If patient is cerebral cryptococoma, then initial therapy started with the amphotericin B or liposomal amphotericin B or uh, amphotericin B lipid complex plus 2 cytosine. And actually, in cryptococcal meningitis in encephalitis and cerebral cryptococoma. In both cases, drug of choice is same. Amphotericin, either amphotericin, liposomal amphotericin, yeah, amphotericin B or either amphotericin B lipid complex along with flu cytosine and, and, along with the flu cytosine. Candidiasis. In the case of candidiasis, initial therapy was liposomal amphotericin B 5 milligram per day with or without oral flucytosine for several weeks. Step down therapy, fluconazole 400 to 800 milligram daily. Therapy should continue until the sign and symptoms of CSF and the everything have resolved. And in aspergillosis, aspergillosis, voriconazole initially loading dose 6 milligram per kg IV every 12 hours for 1 day, and then maintenance dose 4 milligram per kg IV in 12 days, and along with liposomal amphotericin B for intolerant. For intolerant refractory to voriconazole therapy should continue until the sign and symptom and CSF and etiological to have resolved. Mucormycosis. In mucormycosis, liposomal amphotericin B for initial 28 days, and duration of antifungal treatment should be determined on an individual basis, usually continue 46 to 8 weeks. And hypohypomycosis, fusarium voriconazole, and fusarium species every and hypohypomycosis, fusarium and fusarium species, and pseudosporium, opiosperm infection, voriconazole is the provided drug. And in case of histoplasmosis, liposomal amphotericin B and itraconazole for at least 1 year, and until developing CSF and histopath antigen level. In blastomycosis, liposomal amphotericin B and fluconazole, itraconazole, or voriconazole, or at least 12 months until reduction of CSF and mobility. In coccidial meningitis, fluconazole for patient with normal renal functions and without substantial renal impairment, and lifelong treatment. In patients who clinically fail initial therapy with fluconazole, higher doses are first option, and second tender therapy another orally administered. Thank you.
Ravi, Ashish has asked you to add the commonest cause of fungal green abscess, just a fumigatious fungi like Cladophila or a benchana. They all are missing. So you have to add. So if there is any question for Ravi, kindly post your questions.
Thank you so much.